With the rising incidence of pediatric urolithiasis, pediatric ureteroscopy has become a common endourological procedure in patients with kidney and/or ureteral stone disease. Most patients present with an acute episode of renal or ureteral colic to the emergency department. Imaging is based on the hospital protocol, either with KUB and renal bladder ultrasound, or with low-dose non-contrast CT scan. If there are signs of persistent pain, vomiting, urinary tract infection, and based on the size and location of the stone, some of these patients may need intervening ureteral stent placement. After a preoperative evaluation, obtaining a negative urine culture, and waiting 2 to 4 weeks for passive ureteral dilation after ureteral stenting, the patient is subjected to ureteroscopy and dorsal lithotomy position. This is a low-dose stone protocol non-contrast CT scan of the abdomen and pelvis, revealing left distal ureteral stone. It is important to obtain a basic metabolic panel, urine analysis, negative urine culture, and pregnancy test in teenage female patients. Preoperative images are reviewed prior to the procedure. It is important to obtain history of any spontaneous passages of the stone on the day of the surgery. It is important to gather all the accessories necessary for the procedure. The other basic instruments necessary are pediatric cystoscopy set, a C-arm drape, saline for irrigation, radio-opaque contrast, lubricating jelly, and lidocaine viscous for injection into the urethra at the end of the procedure. Shown in this picture are the normal settings for the holmium laser lithotripsy based on the location of the stone. We prefer dusting the stone to reduce the stone migration. Here's a setup of the room showing 2 monitors, one for cystoscopy view, one for the imaging. The holmium laser and the C-arm all set up for adequate view and mobility of the operating room personnel. To protect the operating room personnel, there is a highly absorbent floor mat placed to prevent accidental spills of irrigation fluid. It is critical to make sure that the patient is well padded at the level of pressure points, including the knee and the ankle, as well as taking care of the finger. This can be accomplished with foam pads. Here is a patient who has been appropriately placed in dorsal lithotomy position and well draped, making sure that all of the cords are placed onto the patient without having any pressure points on the patient. Once the patient is placed in the dorsal lithotomy, the operative steps include preliminary cystoscopy to assess if calculus is in the bladder, urine is collected for culture, preoperative antibiotics are given per the AUA guidelines. Under fluoroscopy guidance, a retrograde pyelogram is performed and a guide or glide wire of appropriate size is placed into the renal system. The goal is to be adherent to the ALARA principle and use spot fluoroscopy images to obtain the critical images. After placing the initial guide wire, a dual lumen catheter is introduced under vision and a working wire is introduced in the collecting system. The ureteral access sheath is passed into the ureter based on the location of the stone. Then the flexible ureteroscope is passed under fluoroscopy guidance up to the level of the stone. The stone is visualized. With the holmium laser at the setting which is shown previously, the stone is then dusted to small dust particles, making sure that the stone does not migrate into the proximal ureter. To avoid proximal migration of the stone is sandwiched between the ureteral wall and the laser fiber with the goal to chip and dust the fragments of the stone from one side to the other side. If there are large fragments, they are grasped with the stone basket and retrieved under vision for stone analysis. It is critical to ensure that all of the stones are fragmented or dusted to a small particle and retrieved with a basket under fluoroscopy vision. If there are multiple stones, all stones are addressed simultaneously, from the distalmost first, then proximal stones in the kidney. It is important to systematically analyze all the calyces of the renal collecting system under fluoroscopy as well as with the injection of radioopaque contrast. It is important to keep the irrigation to a minimum. Either a pathfinder or irrigation under pressure is utilized to navigate the ureter. We limit instrumentation and use of laser fragmentation for a period of 60 minutes to minimize trauma to the pediatric ureters. It is important to make sure that there are no residual fragments within the ureter or any calyces of the collecting system. Once all the stones are fragmented and retrieved, appropriate size stent is placed into the collecting system, the proximal loop in the renal pelvis or in the upper calyx, and the distal one within the bladder. It is left on a string for the patient to pull out the stent and home in the next 4 to 5 days. The bladder is completely drained and lidocaine viscous is injected into the urethra. Patient is discharged home with appropriate pain medications. Typically, we do not use antibiotics in these patients if the preoperative urine culture is negative. Patient is instructed to pull the stent out on day 4 to 5 after the procedure. Follow-up is arranged within 4 weeks with a renal bladder ultrasound and a KUB. Thank you for allowing us to share our experience in pediatric ureteroscopies.